Professor Richard Hindley. Richard is lead consultant for urology at Hampshire Hospitals. He's a visiting professor at the University of Winchester. He's the lead at the Girft Academy for bladder outflow obstruction surgery, and most importantly, an avid Chelsea fan. So we'll be delighted to hear Richard's insights into Girft and what is getting it right. Thank you. Put him off his stride.
Right, thank you for that introduction, Max and Magda. Right, so getting it right first time. What is getting it right? I'll run you through some slides and hopefully we'll have a bit more insight into that at the end. Some excellent presentations already and hopefully there'll be some good questions at the end. We all had our reviews in 2016-17 with Simon Harrison and each trust did well in certain areas and maybe not so well in others. And there were lots of learning points on the back of that. And this document was published in 2018, a feedback report, essentially, and with learning points. And that was headed up by obviously Simon Harrison. More recently, we have had or are having our deep dive follow-ups in 2021-22. And again, areas for improvement are highlighted and obviously the variation in practice around the country has been observed and we're trying to learn from that. Model hospital is something that some of you may have been onto, and for a number of procedures we do commonly, we can see where we are and how we compare with our nearby geographical hospitals and nationally how we're doing for each of a number of procedures, including obviously bladder outlet obstruction, which is the academy that I was asked to chair. That involved working jointly with BASU, with BADS, with BOWN, and with NHSE/I. And essentially, you will know this, it's about reducing variation in practice, improving the patient care, and to agree standards as to what constitutes good practice, and to encourage innovative practice and to try and break the convention and think have out of the box ideas about how we might improve the patient journey, which at the moment I think we'd all agree is pretty rubbish, considering that over 40% of men in the snapshot audit from November 2019, I think over 40% of those men were catheterized. And many men are on, this huge national waiting list, waiting for over a year with an indwelling urethral catheter. So these are the sentinel metrics derived from the Girft work done by Simon Harrison, and obviously now the gauntlet is with Kieran, who's in the audience, and John McGrath, and they're doing an excellent job of moving things forwards and trying to make a difference. So the metrics with regards to retention of urine, and I did my research in retention of urine in the 90s with Phil Thomas, and it's very sad that he recently passed away. But my work involved using electron microscopy to look at the ultrastructural arrangement of the human detrusor in a darkened room. But it was at least in Brighton, so you could get outside and enjoy the blue sky and the sea intermittently. What we're aiming for is obviously to improve, raise the bar for all of us across the board. For day case BPH surgery, I mean, this is really important that, if we bring people into an inpatient bed, they then go onto a waiting list. So if we can bring them in and out through our day unit, or even possibly, do them in an outpatient setting, particularly, with Urolift, for example, that really is going to have a positive impact on how we manage those long waiters and how we change radically the waiting list situation. We also need to improve on the waiting time for patients from presenting with acute or chronic retention to how long do they need to wait to have their procedure. And we know that patients come into our hospitals with blocked catheters, with infections, with all sorts of problems, hospital readmissions whilst having a catheter in are not insignificant. So I think we should be listing these at least as P3, we should do their surgery within, or even possibly, do them in an outpatient setting, particularly, with Urolift, for example. That really is going to have a positive impact on how we manage those long waiters and how we change radically the waiting list situation. We also need to improve on the waiting time for patients from presenting with acute or chronic retention to how long do they need to wait to have their procedure. And we know that patients come into our hospitals with blocked catheters, with infections, with all sorts of problems. Hospital readmissions whilst having a catheter in are not insignificant. So I think we should be listing these at least as P3. We should do their surgery within 3 months. But there's an argument really for saying that we should be doing it within a month as P2. So I'll go on to the other points in some subsequent slides. Urolift has been demonstrated to be a reasonable option for men in acute painful retention of urine with good rates of successful, not requiring a catheter after the procedure. And I guess, we could think about if initial TWOC, isn't it, with an alpha blocker, if that fails, why not consider a minimally invasive surgical treatment? That could be Urolift, it could be Resume. We do need more data. These are just retrospective studies. This is being presented next door at the moment as we speak. So for acute retention, I guess it's not perhaps so complex as chronic retention, but essentially getting it right first time is about doing it better than we currently are, because we're not doing it that well for bladder outlet obstruction surgery. We've got to be very patient-centric about what we're delivering, and we've got to move away from this, my TURP is a really good operation, I've done it for 20 years, but actually the subtext is, you don't see them on the ward round on the Saturday, Sunday, and they're still in on a Monday. We've got to give patients more options and all the options that are out there. They need more information, and I'll come on to patient decision aids in a moment, and we really need to work on those timelines. So when I got the email in January 21 from John McGrath, that was essentially part of the content of that email. The goal was to arrive at some materials for each of the 4 academies that BASU and all the other stakeholders can endorse. There's a huge variation in bladder outlet obstruction surgery. These scattergraphs demonstrate that. And we know from the snapshot audit, a significant proportion of patients had an indwelling catheter. That's the breakdown of the numbers that had a catheter in situ or were doing self-cath, and the operations that they had. And if we just remember, the readmission rates and the transfusion rates were highest for monopolar TURP, so we really do need to move away from that. Why is there the variation? I think within each trust or organisation, it's about custom and practice, hospital facilities and geography. Equipment also is important. How easy is it to get new technology into your department? And that varies hospital to hospital. It's about having pathways in place. It's very much about having enthusiasm and a workforce that are interested in making the world a better place. Innovation, I think, needs to be at the centre of this. Clearly, the last 2 years have been a bit of a nightmare and have compounded the waiting list issues, which we all know about and which John McGrath, I think, spoke about earlier in the week. This was the Gerft Academy. We had representation from BASU with Magda. We had representation from BAUN, and we had regular meetings every fortnight for, gosh, it is 7 minutes already. We had regular meetings throughout the year. And then we arrived at this document in January 2022. I ask you to have a look at it. Essentially, we're hoping that it makes a difference to you in your practices and allowing us to come together within networks. But essentially, just to look at it in a bit more detail, this is a guide. So we did actually have references in it as the project evolved. But at the end, we removed them because we weren't competing with NICE. This is a practical guide, but not just for clinicians, but for managers and commissioners. So it's not referenced, and we're not being too prescriptive. There was some content around chronic retention, but we arrived at our advice on chronic retention, and Ferris was part of that, was based on consensus from a group of enthusiasts and experts. Patients in a timely manner. These are the key quality actions. And for each of these domains, there were good practice case studies and are good practice case studies to match, which you can look at in the document. The MedTech funding mandate is obviously helping. 4 of the 11 technologies on that are for BPH technologies. We're still working on a patient decision aid. We're trying to put together a booklet for patients with information. I'm on a waiting list with a catheter in or not, waiting for BPH surgery, and that will go on the NHS website, just to provide them with some support. But I think within that, there is definitely scope for, and there will be, we need to highlight things like, self-cath, using a flip flow valve, etc., because the morbidity of having a long-term indwelling catheter is not insignificant. So I think I've probably finished there, and I'll hand over to Ferris. Thank you very much.